Hello, my name is Mustafa. I'm one of the doctors, and most of you know me. Well, I wish. And I have an interest in care of elderly medicine, and in particular orthogeries. This is our second teaching session to follow on the teaching sessions that we have started recently for our nursing team, as I have felt that the medical team has the largest share of the provided learning or teaching sessions, and it's been very challenging to arrange teaching sessions for our nursing team because you cannot gather all the nurses and take all of them from the wards and to gather them in one place at one time. That's why they take their breaks at different times of the day, and we are very thankful for them. Today's topic is about lying and standing blood pressure, and we want to know what is the significance of lying and standing blood pressure, why we always try to do it, and what's the difference between lying standing blood pressure or just recording the blood pressure in any body position, how we can record lying standing blood pressure, and we will review the guidelines together today. Okay, so we will go over these photos again. The photos of there on the right hand side showing that the water volume can be we can say that it's distributed almost evenly between in the bottle, for example, from top to bottom. Okay, but you can see here that the bottle is lying horizontally or it is sleeping. And when we turn the bottle to the other direction, okay, we will find out that the fluid is only in the lower half of the bottle. And we can use this example as a mirror to reflect, maybe going over these photos again. So in the photo, for example, on the right hand side, you can see that the volume of the fluid, we can say that it's distributed evenly almost between the top and the bottom of the water bottle. But here we're not sure if it is a good amount or if it is more than half, for example, less than half, almost a half, we are not sure. But when we turn the bottle to the other position, for example, we will find out that the fluid volume is within the lower half of the bottle. And we will use this example to mirror the process of recording blood pressure for our patients when they are sleeping and then when they are standing or sitting. Okay, let's talk about four or three factors that usually play certain roles in the process of maintaining our blood pressure within certain limits. It's a very simple anatomy. We are not going to talk about the details. The first factor is our brain, is our first player. Then we will have our blood vessels, and then we will have the heart, and then the last thing, we have two group of sensory bodies. We call them baroreceptors, and there are carotid baroreceptors and aortic baroreceptors. These group of sensory bodies, they are can be found in these areas around the aortic area and around the near the carotid bifurcation. Okay, they're just a group of sensory bodies, and they are attached to the blood vessels wall, and they can sense, for example, if the volume of the blood is adequate or is good, or if it is not good. If it is below, or if it is just like they are just like sensories, or if the blood pressure or the volume of the blood is not good enough, they will stimulate the brain, and the brain then will stimulate the blood vessels or the heart to do something about it. For example, the brain will stimulate the blood vessels to narrow or to constrict in order to improve or to increase the blood pressure, so the blood pressure can go up against the gravity to our brains. Then, or they may stimulate the heart, so the heart can pump more strong or more quick, so and the heart can push more blood into our vessels, and then to have more blood in our blood vessels. Okay, and as we grow older, this process will be affected by certain things. The first thing, that as we grow older, our blood vessels, the walls of our blood vessels will get thick, and we got thicker and thicker, and these will separate the walls from these sensory bodies. So it will make to build up like something like this, and the sensories or the sensors will not sense the volume of the blood in the blood vessels as they used to do. Okay, and or that we may find that there are certain illnesses, for example, that can affect our brain. For example, Parkinson's disease, diabetes, or other illnesses. Okay, or might be we are having low blood volume, and this low blood volume due to a variety of reasons. For example, dehydration or blood loss. Okay, let's move to talk about certain facts about postural hypertension. 30% of the individuals at the age of more than 65, they're suffering from postural hypertension. It is an independent factor or predictor of mortality, and it is associated with falls. And this will lead to significant morbidity. And we will mention very quickly how the postural hypertension or having a postural hypertension will lead to falls. Or we can do it now, maybe. So let's say like if the blood pressure is not good enough, okay, and let's imagine together that here is our brain, okay, here's a brain. This doesn't look like a brain, but if the blood pressure is not good enough, the blood volume will not reach our brain, and this will cause dizziness or lightheadedness. Okay, and what these sensors will try to do, they will pick this up, they will stimulate the brain itself, so it will send signals to the heart, and it will send signals to the blood vessels to improve or send more blood to the brain, either by increase the work of the heart or by narrowing the blood vessels. Okay, that's why maybe in the morning we usually experience that if we stand up very quickly, we might feel lightheaded or dizzy. But as our sensors will pick this up, this process will take milliseconds usually, and then everything will go back to normal. But again, as we grow old, this process will become more slower, because either of these increase in the wall thickness of the blood vessels because of calcification or things like that, or due to a variety of other reasons, either dehydration or blood loss or problem with the brain itself. There are a variety of causes for having postural hypertension. The most important things that we need to look for are medication or dehydration, blood loss, okay, or other systemic illnesses. One of the commonest group of medications that they usually cause drop in the blood pressure are antihypertensive medications or anti-Parkinsonian agents. But the idea is not to know what medications that usually dropping the blood pressure. It's a very good thing to know them. But for the nursing team who are and for the other staff members, the main idea of this teaching sessions is to look for reversible factors that we can reverse, so we can make the likelihood of having these postural hypertension episodes less likely. Okay, so let's see how or what is the ideal way of recording standing and lying blood pressure. First of all, we will ask our patients to lie down for at least 5 minutes. Then we will measure the blood pressure. Then we will ask the patient to sit or stand. When you reach to this level, you need to make sure what is the mobility of your patient. Okay, is there an operation? Has he had an operation or has she had an operation? Or do you need someone to help you to sit the patient or to make the patient standing? We will then record the blood pressure at the end of the first minute or after the first minute, and then we will repeat it after 3 minutes. Then you will note if there is a drop in the blood pressure, how much should be this drop? to make sure to know or to highlight it or to make it more, more to make it more alarming for you, let's say. So the significant postural drop, because our blood pressure may drop when we are sitting or standing or lying. There is some variation, depends on the gravity, but a significant postural drop, it is a drop in the systolic blood pressure of 20 millimeter mercury or more, systolic, or 10 millimeters and or 10 millimeters mercury diastolic. Okay, then you have people with high blood pressure. People with high blood pressure, your cutoff value should be a drop in the systolic blood pressure of 30 millimeter mercury and more. The numbers are not enough. We are not treating numbers, we are treating patients. Then, so we need to find out if these episodes of drop in the blood pressure has been accompanied by other symptoms, for example, dizziness, lightheadedness, or near collapse. Okay, and this is due to the fact that, again, due to the reflex that we have talked about it together. The patient is lying. The sensation or the function of these sensors are not good enough. So when the patient is standing, the blood volume will drop. Okay, do you remember the examples of the bottles? Bottles is sleeping, the bottles is sitting. Okay, so the patient is sitting. Okay, the blood volume is less. The sensation or the sensory bodies are not stimulated enough to start working again, so the blood pressure will not go up and the patient will feel dizzy. Fine. We talked about the commonest causes behind postural hypertension, and we talked about how we should record standing and lying blood pressure. Then, what should be the next step? By the way, all of these posters has been taken from our SASH intranet. They are available on our intranet, and I will print some copies and I will leave them in Sister Janet's office, so all of you can take some copies from there. And so moving again, let's say we have done the lying and standing blood pressure. We found that there is drop, and we need to find if there are any symptoms or not. Why? We are only doing this so we can we can be, let's say, we can have lower threshold to identify the reversible causes, and we can reverse them. So we recorded the blood pressure in standing, we recorded blood pressure in lying, or vice versa, and we have noticed that there is a drop. The next step to notice, is there any symptoms with it or not? Why symptoms? Again, we need to know if it is symptomatic or not. The idea, again, is to know if there are any reversible causes behind these postural drop, so we can have low threshold to reverse them or to correct them. So as a nursing team or as an HCA team, once you find that there is a postural drop, we may need then to assess our patients back to the bed, and then we may need to mention this to our other colleagues, for example, to our nurses or to our physio or to our doctors. Why? Because we need to be more proactive. Okay, so you found this drop. We talked about the medications as one of the causes. For example, we may need to take the drug chart to the medical team, and we will go through the medications together, trying to see which medications can cause this postural drop, right? The other cause is dehydration. So this is quite common, for example, in summer. This is quite common as well in patients waiting for an operation, or for example, when our patients are unable to swallow, they have dementia or other sorts of cognitive impairment. And when we sense that our patient has dehydration, then we may need to send certain blood tests. Okay, for example, to check if there is an AKI or not. Okay, the other reason behind this postural drop, as we have talked about, can be blood loss, which is quite common in patients after an operation or in patients having some sort of GI loss or bleeding from the GI tract. Okay, and so the doctors again can become more alerted to do certain blood tests in order to reverse this possible cause behind this postural drop. Okay, now we talked about um, the causes of postural drop, what postural drop means, what is significant postural drop, how we record postural or standing and lying blood pressure, or how can we act on the result of our readings. Then, what can we do in order to prevent these episodes of postural drop? First of all, we should always encourage our patients to sit out in a chair. And if in bed, we will always make sure that our patients are nursed in cardiac position as much as possible. Okay? All our patients should be as well encouraged to eat and drink when possible. Should be encouraged to eat and drink when possible. And all our patients should be having IV fluids if they are not able to have oral fluids. Then we should always check for their medications. Okay. What can we do next? So we are correcting their position in bed. We are optimizing their diet when possible, giving them IV fluids as an alternative. Then we should always try as well to increase the blood pressure that's going up to our brain. And this can be used by using abdominal binders and TEDS stocking. Finally, there are a few points to take home at the end of today's teaching session. The first point should be how to record sitting and lying blood pressure that we have, and we have viewed this together. The second thing should be we are treating patients, not numbers. Okay, and we need to look at the recordings of the blood pressure not only as numbers. We need to try to identify the reasons behind such levels. If we have, for example, low blood pressure levels, or if we're having significant postural drop, we need to be more proactive, more alert. For example, if you find your patient having a symptomatic postural drop, you may need, for example, to check if the patient is drinking and eating enough, if there is a good amount of urine in the catheter, how dark the color of the urine is. You may want, for example, to check the dressing of the operation if there are any dressings, and you may need to take the drug chart to the doctors, and you can work with the doctor to see if there are any medications that you think we need to stop or adjust so we can help the patients. Or maybe you will notice that your patient has been sleeping in the bed for a very long time, so you will ask our physio, you can ask either the medical team or you can ask our physiotherapist team, so we can maybe trying to move the patient from bed to chair if possible, and we can encourage them to have more exercise. Having exercise in the hospital means having some work with the physio, or just sitting in a chair can be a sort of exercise for the patient. We also may need to know to pay more attention to the way that the patients are nursed in the beds, so we will always try to make them nurse in the cardiac position. Thank you very much for listening, and see you soon.